All right, you're on video.
So, good afternoon. My name is Michael Penix. I am an RN-BSN student at Columbus State University, and today I am doing a presentation on decreasing incidence and severity of ICU delirium in ICU patients. So, as I said, this presentation will describe how to potentially decrease the rates of ICU delirium in patients receiving care in ICU, whether they're mechanically ventilated or not. So, what is ICU delirium? ICU delirium is an acute illness that affects basically the cognitive function, any kind of mental function, confusion, agitation, restlessness are some of the manifestations of it. So I put an image on the slide. This image is a survey of 280 patients. It has 4 age groups down at the bottom. Between 65 and 79 years old, they had 94 patients out of 280 that acquired ICU delirium while they were in the hospital. Second leading is 80 years and older, who had 69. So in relations to our unit, I work in surgical intensive care. So just in SICU alone, over half of our patients have either had surgery or been mechanically ventilated at some point in time. So the incidence of post-op delirium was found to be 15% to 25% among major elective surgery cases, and up to 50% among high-risk surgeries as far as like cardiovascular surgery. So we deal with CABGs a lot, and fractures of the hip. I also put a little joke up there. It's a cartoon that says, "Kids, your mother and I have spent so much money on health insurance this year that instead of vacation, we're all going to go in for elective surgery." So, what do I want to accomplish? So my objectives for this presentation are to bring awareness to my nursing community as far as the severity and the high incidence of ICU delirium among ICU patients. Also inform them of different interventions that are non-pharmacological as far as not using sedative medications to treat patients with delirium. A few of those include early ambulation, limited use of physical restraints, and frequent reorientation. So why did I choose ICU delirium? Non-pharmacological interventions are often skipped when it comes to patients that have delirium. We often just go straight to medications and knocking them out because we don't want to handle it. But we're taught in nursing school to always try non-pharmacological interventions first. And in these situations, those often do help better. When you give patients like that sedative medications, they often tend to become more combative, more rowdy, they're more non-compliant. So either it kind of really works really good or it doesn't work at all. So my ultimate research question is, in ICU patients that are mechanically ventilated or not, how does non-pharmacological interventions compared to pharmacological interventions affect the incidence and severity of ICU delirium? So I chose 4 research articles, all that are evidence-based. My first one is a study on Precedex in ICU delirium. So we use Precedex quite often in our ICU, specifically our surgical ICU, a lot for our CABG patients. So in the past, we believed that Precedex, it has its sedative effects, but we use it a lot because it doesn't decrease the respiratory effort, and it also doesn't make the patient very lethargic. So you can often extubate the patient on this in hopes that they don't get delirium. But new studies have shown that Precedex does not reduce the prevalence of delirium. It can actually often increase it if it's used for long periods of time. And I put my notes on. My second article is about risk factors that can make the patient high risk for delirium, and also about developing a possible score, something like a high risk score. So this study, it surveyed 250 post-op patients, and there were a couple of risk factors that made the patient particularly high risk for delirium. It was age, diabetes mellitus, severity of disease, perioperative use of benzos, and mechanical ventilation. So I said that we should develop a score, kind of like a fall risk score, that will, upon admission, you enter all the patient's information, and it will give you a score from maybe like 0 to 100. Higher will be a higher risk for delirium, and it will cover factors such as age, diagnosis, surgeries that they've had or will have during their hospital stay, past medical history, and current medications. My third article is a quality study on nursing perspectives. So they did a study on an internal study on all of the nurses in their units and basically gained their opinions on how they felt about the PAD protocol. PAD is pain, agitation, and delirium. So they came up with 3 themes as far as the differentiation upon nurse perspectives. One was that nurses had different perspectives on patient wakefulness state. 2, that nurses had different perspectives on pain, agitation, and delirium management in critical care patients, so how it should be gone about. And 3, the factors that affect this management of the patient. So if nurses have different perspectives on how to care for the patient, if there are inconsistencies, it can often lead to improper care of the patient or inconsistent care of that patient as well, which harms the patient in the end. And my 4th article I thought was kind of interesting. It was done in a medical ICU on strictly mechanical ventilated patients. They used music as an attempt to calm the patient instead of using sedation in an attempt to fight delirium. So the patients were grouped into three different groups. The first group, the family chose the music that they liked for the patient to listen to. The second group, they chose music that they thought the patient would like. And the third group didn't receive any music at all. So the results of this study showed that there was in fact an increased state of calmness in the patients that did receive the music versus the patients that did not when they weren't on sedation at all. So what can we do as a team to find a solution? I've come up with 5 things that we can implement upon admission of the patient in order to attempt to decrease their risk of gaining delirium. First is early morning ambulation. So we should be getting the patient up bright and early in the morning, right before day shift comes in, get them up in the chair. This helps them to learn when it's day and when it's night, when it's time to sleep and when it's not, and they'll be more oriented throughout the day. And then they're less likely to gain sundowners and be up all night. Second is adequate rest periods. A lot during the night with me working night shift, I know that we're in and out of the rooms a lot, every hour or so at night. So we should try our best to kind of group our care together so that if the patient is sleeping, we'll only have to go in maybe 3 or 4 times and not disturb them. The third is frequent reorientation. So for our mechanically ventilated patients, if they wake up, if they're confused, if they're combative, we should always try to talk to them, say, hi, you're in ICU, this is what happened to you, my name is so-and-so, I'll be taking care of you, everything is okay, and that kind of calms them down. If the patient feels like they have more of a sense of control over the situation, they tend not to be as anxious. Minimal use of sedative agents. As I said previously, a lot of times sedative agents can make the patient a lot more combative and rowdy. And minimal use of physical restraints, that has the same effect as well. So recommendations. The 2 most important aspects I thought were important for pushing out these interventions is education and feedback. So for one, education, which is what we always do in the nursing field, we should probably try to do in-services, frequent education at staff meetings or at the nurses station, just explaining to the nurses the importance of non-pharmacological interventions for delirium, explaining how it can affect patient outcomes in a positive way, and just reinforcing the importance of it. Feedback. So as nurses, we can often be very opinionated. And if we feel we don't have control over what we're supposed to do during our job, we can push back some. So I feel that gaining the nurses' feedback at the bedside.
Never happens.
I feel like gaining the nurses' feedback at the bedside can increase compliance. They can give their opinions on where the protocol works and where it doesn't, as far as actual direct patient care, and we'll be able to make changes to the protocol as necessary. And my third recommendation was to construct a possible team of maybe 2 to 3 nurses. Once the interventions are pushed out, these nurses will be further trained on the protocol and the ins and outs of it. They can run through the units temporarily, answer questions, address any patient concerns, They can collect data as far as if a patient is diagnosed with ICU delirium, we can record that, and then during frequent time periods, we can have a meeting and discuss why this happened and what can we do differently, and again, provide direct feedback from our bedside nurses. Project evaluation. So my project will be evaluated by success and by nurse compliance. So my hopes are to decrease rates of ICU delirium, decrease use of medication management, and I want to form a program where we update the nurses every 6 to 8 weeks. We can talk about improvement of the protocol, where it fell through at, and possibly any changes that need to be made to it. Expected project outcomes. With persistent education and assistance, I'm sure we'll have good nursing compliance. Management can help with constructing and maintaining the protocols. Patient outcomes will overall improve, and hopefully delirium rates will decrease by 10% within a 6-month period. Conclusion. An overall change in protocol will help to make our patients' ICU stay a little better. Their quality of life will be preserved, and we can in turn help them from returning to the ICU for delirium-related complications, but it will take the entire team. These are my references. And anybody have any questions?
That's awesome.
I think you did a great job. So my first question is, would you be willing to present this at our staff meetings in May?
Sure.
So, because this was a hot topic this morning in our intensivist meeting. Our intensivists feel as if we are still seeing a big barrier in oversedation at night. That our patients, our ventilator weaning protocols are not as, we're not as adherent to that compliance as we could possibly be.
Okay.
So we've had a lot of push, right when I first came on, there was a lot of push to lights on, up, you've heard me say that, blinds open. These patients need to be awake during the day. We need to be making sure that we're not snowing them at night so that we can help them reduce ICU delirium. So there's a lot of work, a lot more work we could do. So I like it. I love the project. It excites me. I love your transition slides.
Thank you.
And our beds do the music, right? The
Oh, yeah.
videos do.
I used
so
to use
we've
it all
got
the time.
music therapy on our beds that's rarely ever utilized. And the TVs you